So papillary thyroid carcinoma, microcarcinoma. Papillary thyroid cancer microcarcinoma is defined as when its diameter is less than 10 mm. And prior to the advent of the high resolution ultrasound, most papillary thyroid cancer cases were discovered by the palpation. And with improved ultrasound imaging and ability to perform guided biopsies of the office setting, subclinical papillary cancers are now being discovered. And in addition, papillary thyroid microcarcinoma, officially found on imaging, performed for other reason, and its treatment has remained controversial. And Mayo Clinic outcome of 900 patients of this PTM over 60 years, they showed an excellent with cause specific mortality of 0.3%, and a total of 30% patients have nodal mats, and with 0.3% having distant mats. And bilateral lobar resection were performed in 86%, with unilateral lobectomy in 14%. And by 20 years, 5.7% patients had recurrence within the neck at the distant sites, most within the cervical nodes, and were not associated with the increased mortality. So higher recurrence were seen in patients with multifocal tumors and having positive margin, positive neck node metastasis at primary resection. And recurrence rate did not differ whether the primary resection include bilateral or unilateral lobe resection, and radioactive iodine ablation that did not improve mortality or recurrence rate. And in summary, in this series, as long as complete resection is possible, more extensive surgery and radioactive iodine ablation, they do not seem to influence recurrence at risk or mortality from primary papillary thyroid microcarcinoma. So in Japanese series of 1300 patients with PTM, they were given choice of surgery versus active surveillance with ultrasonography with no unfavorable features present, and at 5 to 10 years only 6.4% and 15.9% respectively grown with a tumor growth of more than 3 mm. And so those who underwent immediate surgical treatment, the clinical apparent lateral neck node metastasis N1B and male sex, they were independent prognostic factor for reduced disease-free survival. So percentage of patients with this neck node metastasis 5 and 10 year follow were 1.4 and 3.4% respectively. In a recent update of this study, young age was an independent predictor of PTM progression, suggesting that an older patient with subclinical low risk and PTM, they are best candidate for active surveillance. And to summarize, management of PTM should account into reported absence of mortality when diagnosed in the absence of neck node metastasis and distant mats, as active surveillance is very reasonable option and safe alternative to surgery. And a recent meta-analysis examining safety and efficacy of active surveillance in low risk PTC, defined as T1A and T1V N0 M0, reported 1% pooled rate of neck node metastasis and 0.03% rate of mortality due to thyroid cancer, supporting the safety and efficacy even in PTC up to 2 cm in the absence of neck node metastasis or distant mats. And a risk stratification framework has been proposed to help clinicians recognize patients with proven probable PTM most likely to be benefit from active surveillance, while at the same time identifying patients that would be better served as an upfront biopsy or surgical management. So long-term surveillance of this differentiated thyroid cancer with the goal to identify recurrence and patients thought to be free of the disease. And after successful thyroidectomy, ablation of residual thyroid with the radioactive iodine, thyroglobulin is that should be an athyroidic range, like levels below athyroidic range indicative of persistent thyroid tissue or cancer. So typically TSH along with thyroglobulin and antithyroglobulin, they yearly for at least 5 years. For at least 5 years, there should be a period for which most recurrence occur. So the frequency of workup during follow-up visit after the presence of antithyroglobulin, which account for 25% of the thyroid cancer and 10% of the general population, will falsely lower serum thyroglobulin in a patient with low risk disease. TSH suppression level of thyroglobulin less than 0.2 nanogram per ml to 0.5 nanogram per ml represents absence of clinically relevant disease. And neck ultrasound, that should also be performed at 6 to 12 months after surgery, then annually for 3 to 5 years depending on the risk of the recurrence. And radioactive iodine whole body scan reserved for recurrent or metastatic disease. They may not be amenable to therapeutic doses of radioactive iodine, may be amenable. So management of local and recurrent distant metastatic PTC, differentiated thyroid cancer. So significant nodal loco-regional recurrence should undergo modified radical neck dissection or central compartment central compartment level 6 neck dissection depending on the location and recurrence. And more aggressive surgery may be warranted in patients with the invasion of the aerodigestive tract. For smaller neck node metastasis not amenable to surgical therapy or have a distant mets, loco-regional disease control can be achieved using ultrasound guided percutaneous ethanol ablation. Metastatic disease detected with radioactive iodine whole body scan should consider radioactive iodine avid, and it can be treated with iodine 131 therapy. No clear consensus exists regarding dosing of iodine 131, and most experts prefer doses ranging from 150 to 300 millicurie for treating distant metastasis. And treatment beyond can be performed every 6 to 12 months if the disease is continues to respond. However, pulmonary fibrosis, they may limit the further treatment of iodine 131, and for selected patient incurable pulmonary disease, palliative treatment using metastatectomy, laser ablation, and external beam RT may be considered a complete resection of isolated symptomatic bone metastasis. Iodine 131 therapy with radioactive iodine avid widespread disease have both been associated with increased survival, and a combination of treatment may be considered for symptomatic bone lesion when surgery or iodine 131 is not possible or effective. And complete surgical resection of brain mets is most efficacious treatment, where external beam RT or gamma knife, they may be considered in those who are not surgical candidate. Debate regarding the optimal management of patient with thyroglobulin positive but have negative radioactive iodine whole body scan. Important to rule out any technical factors or false negative radioactive iodine whole body scan, including iodine contamination and subductival TSH stimulation. So if the radioactive iodine whole body scan is truly negative, in this setting, if with thyroglobulin positive, management is controversial, and have indicated benefit of empirical therapy of 100 to 200 millicurie of iodine 131. And if post therapy scan is positive, then it is repeated iodine 131 given until the scan is negative. And the idea is that metastasis may be too small to visualize on post therapy scan, or tumor has reduced ability to concentrate its iodine. And this approach is challenged by the result of Mayo Clinic 24 risk patient who detected thyroglobulin with negative radioactive iodine whole body scan, known macrometastasis, and who were treated with radioactive iodine in 1997 to 2000, showed only 2 patients had uptake of post-therapy scan, and hence high-risk patient with known metastasis previously treated with radioactive iodine adjuvant therapy with subsequent negative radioactive iodine whole body scan but positive this thyroglobulin, unlikely to benefit from empirical high dose radioactive iodine. And this is due to reduced iodine 131 accumulation in the persistent disease, likely from dedifferentiated of thyroid tumor metastasis. And FDG PET is helpful in restaging of residual recurrent advances disease in patient with negative radioactive iodine whole body scan but increasing thyroglobulin. So FDG avid lesion associated with an increased cancer associated mortality, and radioactive iodine Therapy is recommended only in patients with significantly elevated thyroglobulin, like more than 10 nanogram per ml, with thyroid hormone withdrawal or more than 5 nanogram per ml with recombinant human TSH. Rapidly rising thyroglobulin and rising antithyroglobulin, in whom imaging have failed to reveal any disease amenable to directed therapy. Ultrasound guided percutaneous ethanol ablation in past DTC with neck nodal metastasis during post therapy surveillance treated with the repeat surgical excision, and ultrasound allowed to discover sub centimeter this neck node metastasis too small for surgical intervention. And in this dilemma, Mayo Clinic and ablated 37 recurrent this neck node metastasis in 25 PTC with stage 3 to 4A disease and showed 95% decrease in size, and none had a significant Doppler flow and none required further intervention. An average of follow-up of 5.4 years, and similar success also been shown with the other institution, and local recurrence in the thyroid bed may also be amenable for ethanol ablation, but results may be limited because of the lack of comparable group and selection bias. We recommend this procedure for patients who are poor surgical candidate, patients who prefer not to undergo repeated neck surgery, those with radioactive ion in refractory disease. Mayo Clinic demonstrated feasibility and safety of ultrasound guided percutaneous ethanol ablation in 15 patients with T1A N0M0 PTC, which require further investigation. Now, if we talk about